From the JAMA Network, this is JAMA Oncology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Oncology.
Hello, and welcome to JAMA Oncology Podcast. I am Vivek Subbiah, MD, Chief Early Phase Drug Development at the Sarah Cannon Research Institute in Nashville, Tennessee. I'm also the web editor for JAMA Oncology. It's my pleasure and honor to host Dr. Kemi from the Department of Obstetrics and Gynecology, Fred Hutchinson Cancer Center, University of Washington. So this paper is about endometrial thickness as a diagnostic triage for endometrial cancer among over 1,400 Black people. Again, Dr. Kemi Dole has contributed as a lead first author. Hello, Dr. Dole. Thank you so much for getting on the podcast.
Dr. Subbiah, thank you so much. It's very nice to meet you. And I was born in Nashville, Tennessee, so I already naturally now have a warm connection to you.
Thank you so much. So I was fascinated by this study. Again, the endometrial thickness as diagnostic triage for endometrial cancer among more than 1,400 Black people. And I was intrigued by the question you asked for this. So in your own words, can you give us a brief overview of your study?
Our overall work in our group is trying to understand where the racial disparities in endometrial cancer come from, where Black people are much more likely to be diagnosed at later stages and also much more likely to die from their cancers. And one of the early modifiable factors we identified in prior work was that it didn't seem to be the case that Black people were getting biopsies at the same rate and seemed to have a different diagnostic pattern around ultrasound and biopsy to determine whether or not endometrial cancer was a potential explanation for abnormal or postmenopausal bleeding. This study really came to be because when we set out to try to answer that question, how accurate is transvaginal ultrasound in the prediction of whether or not somebody coming in with endometrial cancer symptoms needs a biopsy, what we found is that we didn't have a lot of literature directly asking that question. And when we looked at a lot of factors that might influence ultrasound quality, it suggested that this ultrasound pathway may not perform as well in Black people. And so what this study really set out to do is to say, well, let's actually take information from a large group of Black individuals who all underwent hysterectomy, so we know their final diagnosis, and look back to see on their ultrasounds, was this endometrial thickness measurement an accurate assessment of their risk of endometrial cancer?
Can you briefly describe the methods that you used to gather the data for the study?
In a study like this, and with how relatively uncommon endometrial cancer is among people who have hysterectomy, we needed a big sample. So we ended up partnering with a very large healthcare system in the US South that has 10 different individual hospitals where hysterectomy occurs, as well as hundreds of different outpatient practices in order to cast a wide net. And so we used two different methods to get information. One, we used what we call administrative or billing data, where we looked at the actual procedures performed, the diagnostic codes, things that were quite concrete to understand what kind of procedures and when they happened. But then we also, which I think is a huge strength of our study, is we were able to, upon identifying individuals who had hysterectomy, go through their medical records individually in depth in order to pull out all of their ultrasound studies and the results. And for anybody who's listening clinically, they understand people have these procedures, ultrasounds, biopsies at many different locations. We don't have a unified healthcare system. The abstraction allowed us to be able to get information, not just if they had an ultrasound at their native clinic or at the hospital in the healthcare system, but also looking at scanned records, looking at physician notes, looking at nursing notes. I mean, we scoured the electronic record to try to be sure that we got the most accurate and most complete information about the ultrasounds that they had and where they had them in order to do this assessment. So it's a really unique data set because it allows us in a freestanding multi-hospital system to be able to access their care information across multiple different hospitals, multiple different clinics, and even from care that they may have received outside of that hospital system. So we have as complete information as possible.
This is a retrospective diagnostic study of abstracted health record data and secondary administrative data from the GUIDE EC sample. So, how does the false negative probability of the transvaginal ultrasound strategy, triad strategy, for endometrial cancer diagnosis among Black individuals compare to previously reported estimates? And what are the implications of this difference?
The reason why the transvaginal ultrasound triage strategy began was because of population-based studies that suggested negative predictive values in the 99% to 100% range, and endometrial cancer cases under the diagnostic threshold at less than 1%. So this strategy was adopted assuming that it would just be very unusual to essentially miss a case of endometrial cancer. I think we quote prior literature where it was like maybe 0.4%. So when we set out to do this study, we simply wanted to ask the question, well, if we have a large group of individuals who didn't have endometrial cancer and we have their ultrasound reports, we can ask the question directly among this higher risk group of individuals, how many who had endometrial cancer ended up having measurements below the threshold that would not have actually indicated their risk of endometrial cancer. And so it is disturbing because we found much higher false negative probability than we really wanted to see, in terms of that being definitely significantly more than 1% at each of the thresholds, up to 11% at 5 millimeters. Just another thing that I wanted to add is that we did look at sensitivity and specificity, which is reported across different studies. We tend to see those numbers in the 95% or higher range. In this population, the sensitivity was 96% for the 3 millimeter range, but it fell below that for the more commonly used 4 and 5 millimeter ranges. So looking at it in either direction, this strategy is not performing as well as we would assume, considering that the entire purpose of the ultrasound is simply to indicate whether it is worth pursuing a biopsy or not. And so when that is a false reassurance that no biopsy is needed, that's the potential for quite a bit of harm for a patient and a provider who might assume that their bleeding is not from a malignant cause.
What were the main findings regarding the performance of transvaginal ultrasound measured endometrial thickness thresholds in ruling out endometrial cancer among Black individuals, particularly in relation to known risk factors such as age, postmenopausal bleeding, and BMI?
I have to say this part surprised me a little bit because I thought we might find some issues with accuracy, but perhaps among the individuals that we have identified as being most at risk for endometrial cancer, those that are older in age, those that have postmenopausal bleeding or have higher BMIs, perhaps this strategy would function very well. What we found is that it didn't really make much of a difference, so that those false negative probabilities were very similar across those different risk factors, which just means that we can't say that among individuals that we are most concerned about, the strategy does work well, because we found that it didn't work well when they were older, it didn't work well when they presented with postmenopausal bleeding or with high BMI, all of which are increased risk factors for endometrial cancer.
You hypothesize some of the factors to influence the accuracy of endometrial thickness measurement, such as endometrial visibility, presence of fibroids, and pelvic vein. So in your assessment, how do these factors impact the reliability of the transvaginal ultrasound triad strategy?
One of our driving hypotheses was that with Black women having a higher incidence of fibroids, especially submucosal fibroids that obscure the endometrium, that one of the etiologies of this inaccurate measurement, or the measurement not performing the way we think, is the presence of fibroids. We also thought about potentially people with pelvic pain not necessarily having the most clear ultrasound results just because of discomfort with the procedure, and then also visibility as its own category. What we found is that of those three, visibility definitely seemed to be a driver of this inaccuracy, where if we just looked at the cases where endometrial visibility was partial but not complete, the false negative probability actually jumped up to 26%. So again, it really emphasizes that if the strategy even is going to be used, we really need to ensure that there is complete and total high quality visibility of the endometrial thickness and not a partial measurement.
That comes to the study's limitations, right? Including the exclusion of cases not treated with hysterectomy. So, how might the findings be generalized to a broader population of Black individuals at risk of endometrial cancer, especially those who may not undergo surgical intervention?
So I would say that by restricting to only a population with hysterectomy, so we could have the gold standard diagnosis of the presence or absence of endometrial cancer, we captured a more symptomatic group of individuals in general than everybody who presents with bleeding. So what that means is that if those who don't have cancer tend to also have a more thin endometrium, then the rate of endometrial cancer among those individuals would be lower in the general population. However, it wouldn't change the fact that among those with endometrial cancer, we still see unacceptable performance of this threshold in terms of its accuracy. So, what I would say is that ultimately we hope that with endometrial cancer, surgery is the mainstay of treatment. So, everybody who eventually is diagnosed with an endometrial cancer will have a hysterectomy. In that sense, what my hope would be among folks who don't eventually get a hysterectomy is that they didn't have endometrial cancer, but they had an appropriate triage process that could rule out that potential outcome accurately.
So, what are the implications of these findings for clinical practice, particularly concerning the reliance of transvaginal ultrasound triage for endometrial cancer diagnosis in Black patients? And what alternative diagnostic strategies are further research avenues suggested?
Thank you for this question. I think it is the important question at the end of doing this kind of research. Firstly, is transparency and communication with patients that using transvaginal ultrasound as the initial screen to determine whether or not they need an endometrial biopsy in the presence of potential symptoms of endometrial cancer, has this error rate. I think people need to be able to hear that and then decide what makes the most sense for them. For Black individuals who have a higher risk of more aggressive endometrial cancer, more aggressive histology types, there needs to be a clear discussion of the pros and cons of avoiding biopsy versus going with a strategy that may not be accurate, especially if they have other risk factors. My hope is that what this means is that in the interim time right now, our alternative diagnostic strategy is really tissue diagnosis, an endometrial biopsy or a DNC. I think that must be pursued if there is a question of potential endometrial cancer in a patient presenting. However, I'm really hopeful in the future that we can have less invasive but still accurate diagnostic strategies. And I know there's work being done looking at vaginal pooling and liquid in the vaginal canal that can be assessed for endometrial cancer, even urinalysis, looking for potential shedding of endometrial cancer cells. There's a lot of work being done to try to, and even blood tests to try to determine other ways that we can more accurately get at this than tissue biopsy, which of course is invasive and can be painful for patients. But right now, I think the most important thing that I would say is transparency and communication with patients about this risk of false negative results from an ultrasound, especially Black individuals, and then engaging in shared decision making about the relative invasiveness and their priorities in terms of moving forward to evaluate bleeding or other concerning symptoms.
So, as we are concluding, any final comments, next steps that you envision from this research?
We do have several more papers lined up from this really valuable and rich data set looking at different symptom presentations, as well as some of the risk factors for being in the delayed diagnostic groups. I'm hoping all of this allows us, in the setting of a cancer that is increasing every year, whose mortality rate is increasing every year, and the disparities are increasing every year, I'm just really hopeful that our work continues to allow us to improve the quality of care from the diagnostic period all the way through. So thank you very much.
It's been a pleasure and honor to host Dr. Kemi Dole, lead author on endometrial thickness as diagnostic triage for endometrial cancer among over 1,400 Black people. So the transvaginal ultrasound triage strategy is not reliable among Black adults at risk for endometrial cancer. In the presence of postmenopausal bleeding, tissue sampling is strongly recommended. So as the saying goes, if tumor is a rumor, tissue is the issue.
Yes.
And again, thank you so much, everyone, for listening. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.